Welcome everyone to this deep dive on anti-anginal drugs, especially for those of you following along on KMR Advise. Our medical students in India, this is such a cornerstone topic.
It really is.
Chest pain, angina, you're going to encounter it very frequently. So understanding how to manage it pharmacologically is, well, it's essential for your future practice.
Absolutely right. Angina is common, and getting a firm grasp of these medications, when to use them, how they work, the potential problems, it's going to be incredibly valuable. We'll definitely take our time today, keep a slow pace for clarity.
Precisely. So our mission here is pretty straightforward. We want to thoroughly explore anti-anginal drugs, and we'll do that by following the structure of the anti-anginal drug guide you might have seen on the KMR Advise YouTube channel. We won't miss any sections.
Good plan.
And guiding us through this, offering expert insights specifically for our KMR Advise audience, we have our expert with us.
Welcome. Thank you. Happy to be here and share some thoughts on these vital medications for all the students watching KMR Advise. And hey, make sure to share this with classmates, subscribe to KMR Advise, and, hit that bell icon so you don't miss out on future content.
Great reminder. Okay, let's start with the big picture, the broad uses. Our guide mentions their primary tools for angina pectoris, both for, immediate relief and for prevention.
Exactly. It's about tackling the acute attack, but also long-term management, improving quality of life.
Right. And not just stable angina. They're also used in more serious situations, like unstable angina, ACS.
Yes, definitely. In those cases, they're part of a combination therapy, of course. They help ease the strain on the heart, reduce the pain.
By reducing oxygen demand, right?
Correct. Helping to stabilize things, prevent more damage in those critical moments.
Now, the guide also mentions uses beyond angina, like congestive heart failure, acute LVF. As vasodilators, can you elaborate on that?
Sure. So by widening blood vessels, especially the veins, nitrates reduce the blood returning to the heart, the preload.
This makes it easier for a struggling heart to pump. They also slightly reduce afterload, the resistance the heart pumps against, so it eases the workload overall.
And then these other uses listed: biliary colic, esophageal spasm, even cyanide poisoning for nitrates. That seems quite diverse.
Yes, less common, but good to know. The smooth muscle relaxation helps with colic or spasm pain. And with cyanide, well, nitrates create methemoglobin, which binds cyanide. It's a fascinating, though rare, application.
Fascinating is right. Okay, let's get into the classification. How are these drugs grouped? The guide starts with nitrates, action, venodilation, decreasing preload. Examples like GTN, isosorbide dinitrate, isosorbide mononitrate.
And popular Indian brands for our KMR Advise viewers: Angist, sorbitrate, monotrate.
Yes, you will see these very often in India, especially the sublingual ones like Angist. They're crucial for rapid relief in an acute attack.
Okay, then we have the beta blockers. Main action: decrease heart rate and contractility.
Right.
Examples: propranolol, metoprolol, etenolol. Brands like Indrel, Betaloc, Aten.
Beta blockers are really a cornerstone for long-term chronic stable angina management. Slowing the heart, reducing its force. It lowers oxygen demand significantly.
Next, calcium channel blockers, CCBs. Primary action: arteriolar dilation.
Widening the smaller arteries, yes.
Examples like verapamil, diltiazem, nifedipine, amlodipine. Brands like Calaptin, Dilzim, Nicardia, Amlong.
It's quite a diverse group, the CCBs. You have the dihydropyridines like nifedipine and amlodipine, mainly dilating arteries. And then the non-dihydropyridines, verapamil and diltiazem, which also slow the heart rate quite a bit.
Okay. Then there's a potassium channel opener, Nicorandil, brand name Nicoran. Also causes vasodilation.
Right. Nicorandil works by opening potassium channels in vascular smooth muscle. It affects both arteries and veins, actually, which can be useful.
And finally, this others category: trimetazidine and ranolazine, ivabradine. Brands like Metagard, action is described as metabolic or other.
Yeah, this is a mixed bag. Trimetazidine helps the heart use energy more efficiently, especially when oxygen is low. Ranolazine affects ion channels. Ivabradine specifically slows heart rate at the SA node, often used as add-on therapies.
Add-ons when the main drugs aren't enough.
Exactly, when things are refractory.
Got it. Okay, let's highlight some key notes for each class. For nitrates, first line for acute relief, especially sublingual. But also this issue of tolerance, needing a nitrate-free interval.
Yes, that rapid onset of sublingual nitrates is vital for acute pain, but continuous use leads to tolerance. The body just stops responding as well. That nitrate-free period, usually 6 to 8 hours, often overnight, is absolutely essential to maintain effectiveness.
Okay, for beta blockers. First line for chronic stable angina.
Yeah.
And they reduce mortality in IHD, which is huge.
The major benefit, yes.
But crucially, not for variant angina. They might even worsen it.
That's a critical point. Beta blockers are great for reducing workload in typical angina. But in variant angina, caused by artery spasm, blocking beta-2 receptors might actually constrict the vessels more. So generally avoided there.
Right. Okay, CCPs. The notes say dihydropyridines, like nifedina, are preferred for variant angina, while non-DHPs like verapamil are more for rate control. And CCBs are useful if patients can't tolerate beta blockers.
Exactly. So for variant angina, a dihydropyridine CCB is often a better first choice. If you also need rate control, maybe a non-DHP, but carefully. And yes, they're a good alternative if beta blockers cause side effects.
And nicorandil. The note says it's used when others are inadequate or contraindicated.
Basically, yeah. Often a second or third line choice when the first line drugs aren't cutting it or can't be used.
And the others? Add-on therapy in refractory angina with specific indications.
That's right. You might add something like trimetazidine or ranolazine if someone's still having pain despite being on, say, a nitrate and a beta blocker or CCB.
All right, let's dive into the mechanisms of action, the MOA. How do these actually work? Nitrates first. They release nitric oxide, NO.
Correct. In the smooth muscle of blood vessels.
Which increases cyclic GMP, cGMP, leading to vasodilation. Mostly veins, reducing preload, some afterload reduction too. And they dilate large coronary arteries.
Yes, that's the core mechanism. Dilating veins reduces heart workload. Dilating coronaries improves oxygen supply to the ischemic muscle itself. Two key actions.
Okay. Beta blockers. We said they block beta-1 receptors in the heart, decreasing heart rate and contractility, reducing myocardial oxygen demand.
Simple but very effective. Makes the heart work less hard, need less oxygen, restores that supply-demand balance.
Yeah. And CCBs inhibit L-type calcium channels, causing vasodilation, mostly arterioles this time, and decreased contractility, especially with verapamil and diltiazem.
Right, so they reduce the resistance the heart pumps against the afterload, and the non-DHPs also directly weaken the pump and slow the rate.
And the others. Nicorandil opens K+ channels for vasodilation. Trimetazidine and ranolazine modulate metabolism.
Exactly. Nicorandil relaxes blood vessels via potassium channels. Trimetazidine affects energy metabolism, makes it more efficient in low oxygen. Ranolazine has complex effects on ion flow. Different approaches.
Okay, let's switch gears to pharmacokinetics. How the body handles these drugs. GTN, sublingual, very fast onset, 1-2 minutes, but short duration, 10-30 minutes. Liver metabolism, urine excretion.
That rapid onset is why it's the go-to for acute attacks. But yeah, it doesn't last long. Not for prevention.
Isosorbide dinitrate, sublingual. Slightly slower onset, 5-10 minutes. Longer duration, 20-40 minutes. Also liver metabolism, urine excretion.
Right. Dinitrate can be used for acute relief too, and longer-acting oral forms exist for prevention.
Isosorbide mononitrate, oral. Slower onset, maybe 30 minutes, but lasts much longer, 6-10 hours. Same metabolism and excretion.
Yes, the mononitrate's longer action makes it suitable for once or twice daily dosing for chronic angina management. More convenient.
Beta blockers, oral. Onset 1-2 hours. Duration varies quite a bit depending on the specific drug. Liver metabolism, urine excretion again.
That variability in duration among beta blockers is important clinically. It affects dosing frequency.
NCCBs, also oral. Onset varies too, 1-6 hours. Duration also ranges widely, 4 to maybe 24 hours. Liver metabolism, urine excretion.
Yeah, a huge range. It allows tailoring, needs short-acting, frequent doses, or long-acting once a day. You have options with CCBs.
Our guide has some clinical pearls. First, GTN tablets. Keep in tightly closed glass containers. Why glass?
Ah, good point. Nitroglycerin is volatile. It can evaporate or get absorbed by plastic. Glass protects its potency. Keep it away from heat and light, too. You want it to work when needed.
Makes sense. Second pearl. The nitrate-free interval, 6 to 8 hours daily, is crucial to prevent tolerance. We keep coming back to this.
We do, because it's so important. For everyone on KMR advice, remember this. That daily break lets the body reset its sensitivity, usually done overnight when activity is low.
Right. Let's talk adverse effects. Vascular ones like headache, flushing, hypotension. Common with nitrates and CCBs. Why?
It's a direct result of the vasodilation. Widened vessels in the head cause headache. More blood flow to the skin causes flushing. And overall vasodilation drops the blood pressure.
How do you manage those?
Well, tolerance often develops to the headache, thankfully. For hypotension, advise patients to stand up slowly, especially when starting the drug or increasing the dose. Avoid dizziness.
Okay. Cardiac side effects.
Yep.
Bradycardia, slow heart rate, AV block, can happen with beta blockers and non-DHP CCBs.
Yes, like verapamil, diltiazem.
When are these particularly concerning?
Big concern if the patient already has heart block or a very slow heart rate to begin with. These drugs can worsen it significantly, so they're avoided or used very cautiously in those cases. Heart rate monitoring is key for anyone on these.
CNS effects like dizziness, weakness are also listed.
Right. Usually managed with reassurance, rest, staying hydrated. If severe, maybe adjust the dose.
And under other, methemoglobinemia. Rare, with nitrates, rashes, tolerance, dependence. We covered tolerance. What about methemoglobinemia?
It's where iron in hemoglobin gets oxidized, reducing oxygen carrying capacity. Rare, but serious, usually only with very high nitrate doses. Dependence isn't really a major physiological issue, but maybe some psychological reliance on that quick relief from sublinguals.
Okay, contraindications. When should these absolutely not be used? For nitrates, severe hypotension shock, and recent sildenafil use. Why is the sildenafil combo so bad?
The sildenafil interaction. Both drugs cause vasodilation. Sildenafil via PDE5 inhibition, nitrates via NNO. Together, the drop in blood pressure can be profound, catastrophic even. Risk of MI, even death. A huge contraindication. Everyone needs to know this one.
Absolutely critical. For beta blockers and non-DHP CCBs, absolute contraindications include significant heart block or bradycardia.
Makes sense, right? Given they can slow the heart and conduction themselves, using them in someone already compromised can lead to serious rhythm problems.
Then, relative contraindications used with caution.
Yeah.
Non-selective beta blockers in asthma or COPD.
Yes, because blocking beta-2 receptors in the lungs can cause bronchoconstriction, worsening breathing problems. Cardioselective beta-1 blockers are generally preferred, but still used cautiously.
Beta blockers also relative contraindication in variant angina, as we discussed, and severe anemia for nitrates. Why?
Well, nitrates lower BP. In severe anemia, oxygen carrying capacity is already low. A further drop in BP might be poorly tolerated, worsen symptoms.
Okay. Drug interactions, we hit the nitrate plus sildenafil one hard. Any others?
Yes. Combining beta blockers with non-DHP CCBs, think verapamil or diltiazem, can cause severe bradycardia or AV block because their effects are additive.
Right.
Also, combining nitrates with other BP-lowering drugs can lead to additive hypotension, and alcohol can enhance nitrate effects, increasing dizziness risk.
Good points. Dosage and more clinical pearls. GTN sublingual. 0.5 milligram tablet, repeat every 5 minutes, max 3 doses in 15 minutes.
That's the standard acute protocol. If pain isn't gone after 3 doses or worsens, seek immediate medical help. Could be an MI.
Isorbide denitrate. 5-10 milligrams slow oral immediate release, 20-40 milligram oral sustained release.
Shows the flexibility. Acute relief or longer-term prevention.
Beta blockers. Dosage needs titration to heart rate and BP. And avoid abrupt withdrawal. Why is stopping suddenly bad?
Very dangerous. Abruptly stopping can cause a rebound effect, sudden jump in heart rate and BP. This can trigger angina, MI, even sudden death in susceptible patients. Always taper off slowly under supervision.
Crucial. And CCBs. Dose varies a lot by agent. Adjust for response and side effects.
Yes, highlights the need for individualization. Finding the right CCB and the right dose takes careful monitoring and adjustment.
The pediatric note is simple. Antianginal is not routinely used in children for angina.
Correct. Angina from coronary disease is extremely rare in kids. Chest pain in children usually has other causes managed differently.
Okay. Toxicity and management. Nitrate overdose. Severe hypotension, syncope.
Action.
Lay flat, give IV fluids.
Supine position helps brain blood flow. Fluids boost volume. Basic supportive measures first.
Beta blocker toxicity. Bradycardia, heart block. Management. Atropine. IV fluids, maybe pacing.
Right. Atropine counters vagal effects to raise heart rate. Fluids support circulation. Pacing might be needed if bradycardia or block is severe and unresponsive.
CCB toxicity. Again, hypotension, bradycardia. Treatment. Vyegui calcium. Vasopressors. Why calcium?
Calcium can help overcome the calcium channel blockade, potentially improving heart contractility and raising BP. Vasopressors directly constrict blood vessels to raise BP in severe cases.
Black box warnings and keynotes recap. Nitrates, tolerance and dependence with continuous use.
Reinforces the need for that nitrate-free interval, as we've stressed.
Beta blockers. Avoid abrupt withdrawal risk of rebound angina MOI.
Again, critical point about tapering.
And the GTM plus sildenafil warning. Potentially fatal hypotension.
Can't emphasize that one enough. These warnings highlight major risks if not used properly.
Moving to high-yield facts for our KMR-advised viewers. Nitrates, drug of choice for acute anginal relief.
Absolutely fundamental. Sublingual nitrate for acute pain.
Beta blockers, Reduce mortality in stable angina IHD.
A key long-term benefit. They improve outcomes, not just
And
symptoms.
CCBs, preferred invariant vasospastic angina.
Because they directly counteract the coronary artery spasm, the hydropyridines especially.
Perfect. The guide ends with an antianginal drugs final exam checklist. Very useful for students on KMR advice, MOA summary, nitrates, NOC-GMP, beta blockers, AHR contractility, CCBs, vasodilation.
Know these core mechanisms.
Key drugs, GTN, isosorbides, propranolol metoprolol, verapamil diltiazem nifedipine.
Get familiar with these common examples.
Contraindications, nitrate plus sildenafil, beta blockers, invariant angiogenesis.
Knowing when not to use them is vital.
Toxicity, headache, hypotension, nitrates, bradycardia, beta blockers, SCCDs.
Be aware of common side effects for monitoring.
Clinical pearls, nitrate-free interval, avoid abrupt beta blocker withdrawal, tailor therapy to angina type.
Practical points for clinical practice.
And a final exam tip, nitrates for acute, beta blockers for chronic stable, CCBs for variant. But always individualize and monitor.
A good starting framework, yes. But remember, combination therapy is common and patient factors are key. Always think about the individual.
So just to summarize quickly, we've covered the main classes: nitrates for preload reduction, beta blockers lowering heart workload, CCBs dilating arterioles. We hit their uses, mechanisms, pharmacokinetics, side effects, contraindications, interactions, all following that KMR advised guide structure.
And understanding all this is just so crucial for managing angina effectively in India. Remember the differences, the acute versus chronic roles, and those vital safety points like contraindications and interactions.
Absolutely. For everyone watching on KMR Advice, please review this material. Focus on those mechanisms, the class differences, and the clinical considerations.
You know, as future doctors, this knowledge is fundamental for safe and effective care. Think about how the pharmacokinetics onset, duration, and the MOAs dictate how you use these drugs in different clinical scenarios. It's about applying the knowledge.
Couldn't agree more. Thank you so much for sharing all these valuable insights.